myself, Dr. Hiral Solanki, welcomes you all on behalf of Parul University and Faculty of Physiotherapy for PU webinar. Let me introduce our guest speaker, Dr. Ashok Trivedi. Sir has done Bachelor of Physiotherapy from MS University Baroda in 2009. He completed his postgraduate diploma in Hospital and Health Care Management in 2011 from Symbiosis University. He has also completed his postgraduate diploma in Psychology Counseling from Indian Institute of Counseling in 2013. He is a certified yoga trainer from Yog Niketan. He has 12 years of experience in field of rehabilitation as clinical physiotherapist. He is working as a senior physiotherapist in Jaya Rehabilitation Institute and Research Center, Bidda. He is a life member of GSCPT, IAP, as well as IAAT. He is also a member of Executive Committee of Indian Association of Associative Technology. He is an integral member of Technology Transfer for Rehabilitation of Earthquake Victims. He is also working for prevention and examination of foot and spinal deformity in child healthcare camp. He has presented many papers in national and international conferences in the field of rehabilitation. He has also delivered webinar during the corona pandemic for continuous education for rehabilitation profession. It is our honor and privilege to have Dr. Ashok Trivedi sir with us. I would like to request Dr. Ashok Trivedi sir to start the session.
Thank you so much, Hiral. I am very much thankful for the Parul University to organizing such kind of webinar. First, congratulate them. And I am also thankful to them that given me opportunity to share my experience related with the comprehensive rehabilitation of Gullian Barre syndromes. We all are aware about that Gullian Barre syndrome. It is nothing but it is a low motor neuron disease, and it is a one kind of we can say that a polyneuropathy. So why it's a comprehensive rehabilitation of any kind of rehabilitation? We all are going for the rehabilitations, but we are going for the rehabilitation in different part. Physiotherapist is going for the physiotherapeutic rehabilitations. If occupational therapists are there, they will go for the occupational therapeutic rehabilitation. Some orthotics are there, they are going for the orthotic rehabilitations. But comprehensive rehabilitation means all these members will come together and they will go for a work together for a rehabilitations for the patient. That is a comprehensive rehabilitations. So what is Gullian-Barre syndrome? Actually, a Gullian-Barre syndrome, it is nothing but it is an acute inflammatory demyelinating disease. It's not like that it will affect only kids, it will affect only the geriatrics, it will only affect a male or female. It can affect any person. It's not the special criteria is not that it will affect only this group of people or this group of sex. About 50% of patients will initially develop abnormal sensations. 25% begin with a combination of abnormal sensation and weakness. Sometimes 25% will develop initially a muscle weakness. So pain is very common in them because they are experiencing a deep aching, cramping pain in buttocks, thighs and between shoulders sometimes. The disability is caused by the Gullian-Barre syndrome generally progresses over the course of a few days to 4 weeks, with a weakness starting distally and ascending in a manner for hours or days. At a peak of conditions progress, the many patients experience flaccid paralysis or nearby all skeletal muscles. Some patients will also finding a difficulty with the talking, swallowing and breathing frequently being affected. So there are 70% of patients lose some strength in respiratory muscles also. So that's why they have a shortness of breath. In about 1/3 of patients, intubations or ventilator temporarily become required. Consequently, mostly newly diagnosed patients were firstly placed in an intensive care unit as a precautions. The plasma exchange and a dose of intravenous immunoglobulins often fastens the recovery. Fortunately, the GBS typically is a self-limiting with improvement usually beginning spontaneously and after the weakness has been maximizes. The death rate is 3% and the recurrence rate is also there. I have one experience is there. The girl has been at the age of 17 years. She has affected with her GBS, but when we have collected her history, she has this is a recurrent attack for her because she has been also affected by the GBS at the age of 5 years as well. So recurrence is also possible. So what about the recovery? The many patients are there. They can walk without aids within 3 months. They will experience only minor residual symptoms are there. Some might have some foot drops are there. Some might have some intrinsic hand weakness are there following the onset. But nevertheless, like weakness, the recovery can be extremely slow sometimes. And 5 to 20% patients are there. They will left with a significant residual symptoms. The long-term disability is also possibilities are there and to prevent a successful return to their prior lifestyle occupations. So I think everybody is aware about the ICF classifications. Whenever any conditions are there, any diseases are there, it will affect the body functions and structures, which we are calling as the impairment. Impairment does not restrict us at any places, but the impairment will limit our activity at some places. If we are not able to move our elbow, we are finding a difficulty in activity to flexing it or to extending it. So ultimately it will restrict our feeding. So it will restrict the participations. So this concept is, I think everybody is clear about it, but the activity is also affected by the environmental factors as well as the personal factors that I will also explain it later on. So some basic idea about what is the neural rehabilitations. So some basic approaches are there which we are following whenever we are treating any kind of neurological rehabilitations. It is not like applicable for the GBS only. It can be used for the spinal cord injury as well as the stroke. So rehabilitation is nothing but it is an active and dynamic process. Please careful, it's an active. Active means active involvement of patient is very much important in this approaches. Second is dynamic. It is not a static one, means we have to follow only a single protocol is suitable for one patient and we will continue with it. It should be dynamic. It will keep on changing and process which are through which we can put a disabled persons to help to acquire a knowledge and skills in order to maximize their physical, psychological as well as social functionings. This process is conveniently broken down in three key areas. First one is approaches to reduce that disabilities. As if we have a case of GBS are there, we know that the patient has a weakness of dorsiflexus as well, wrist extensors are there, and due to the gravity, when your patient is going for the lying in a bedridden position, there is a chances are that the foot remain in a plantar flexion. So there is a chance of foot drops are there. That foot drops can be converted into the future the equinus deformity. So our first approach will come how we can reduce such kind of disabilities in the patient. The second approach is we will decide to acquire new skills and strategies which will maximize the activity. Sometimes if you are saying to patients, okay, get up and you can, some common examples are the ONE. When we will ask the patient, means you can walk very nicely, why you are not, no, I have a pain. I have too much pain is there, I am not able to walk. But with the single changes are the new skills, they are not used to with a cane. So if we will teach them how they can walk with a cane, so little bit of weights shifting towards the one places. So with weight shifting, they can walk very nicely, but it is a new strategy for them. Sometimes when you are patient going for the climbing, they can't climb the stairs one by one simultaneously. So we can teach them with the two steps, then again climb it, then again climb it. Again, break is needed. Fatigue. If somebody has a fatigue, somebody has a endurance is low, stamina is not there. We can tell them you have to go for a little bit of hold or the rest in between. So these are some new skills and strategies which will maximize the activities of the patients. And third approach is which will help us to alter the environment, both physical as the social. Some examples are like ONE patients. We are telling them you don't have to sit on a floor, but are we saying that you do not have to sit at all? They can sit, but they have to sit on a chair. They can sit on a sofa. So wherever the height is there, the knee is not going into the complete flexions. With a 90-degree of flexion, patient can sit at any places, though it's a chair or sofa or table or stool, whatever is there. But ultimately, we are not allowing the patients, they can go for the full flexion of knee and the extra burden on the knee. So we have to just change the environment. So this is the third approaches. And the neuro rehabilitations as what we are doing and what I prefer as per my experience is only 7 steps are there, which will be easily to remember. With these 7 steps, we can go for the any neurological rehabilitations. The first of all is the selective stretching. Sometimes every muscle does not need a stretching. Some examples are the in GBS patient. Patient does not has a quadriceps, their hamstring is also weak. All muscles are weak, but sometimes the hamstring tightness will help the patient to extend the knee and lock the knee in a 0 degree of extensions. So if in such kind of patients we will go for the stretching of the hamstring, it will ultimately weakens the hamstrings. So earlier on, patient is able to stand with the help of tightness of hamstrings. But as we will stretch it and it will become weak, patient might be going to fall. So ultimately, our stretching has restrict the patient's functions. Patient is not able. We want patient functional, but it will restrict the patients, and patient will not become a functional. So that's why selective stretching is needed. Same way, selective strengthening is needed. So many times we are going for the back actions and back actions and back actions. But I have seen in my some patients, if whenever we are telling the patients, if they are sitting on a high stool or the high sitting positions, and we will tell them you can touch to the ground and come back. So two varieties are there. Some patients are there, they will just keep their hand straight and they will come back. When they are doing these things, their back actions are working very nicely. But whenever patient is coming with a flex elbow, and by the extensions of the shoulders as well, with the adductions, they are using a latissimus dorsi. So the wrong strengthening manner, the selective strengthening is needed. We want to strengthen the back extensions, but back extensions, especially which muscles we want to strengthen it, we have to strengthen it. The third thing that is come a balance training. The balance training, sometimes we will always think about it. Balance training, okay, we have to put patient on a balance board. We have to put a patient on a vestibular board. It is not like that. Balance training means the ideal rule we have to just change the center of gravity or line of gravity. So simple perturbations we can use it. So if patient is in a lying position, their core muscles are not working. In side lying also we can go for a balance training for the patient. And once patient has achieved some side lying is there, half sitting is there. So in half sitting we can go for the balance training. Again in a sitting balance training. As patient is gaining their strength, we will advance the higher the center of gravity, we can lesser the base of support, and with that we can achieve a good balance training in the patients. Fourth thing is a gait balancing. We all are, as a physio, I know that when your patient come to us, we want that let the patient to be a walk. We want to make them a mobile as early as possible, but we are forgetting that when your patient is going for the any gait pattern, okay, patient needs some balancing. When we are moving one leg ahead, the whole weight is coming on the another leg, and that leg should be stabilized. If that leg is not balanced properly, we can't lift our another leg. That's why balance training, sometimes walk standing balancing are there. In our case, for whichever patients are coming to us, what we are doing that initially whenever patient we are putting on a walker now, we will teach them first them a walker balancing. In walker also the some gait balancing exercises, one patient will master with it. We can put them on a crutch, and once they will become on a crutch, the safety with the safety precautions, if they are able to do all that, then we will teach them without support. But before starting the gait training, we are going for the gait balancing as well. The fifth thing, that is the transitional training. Transitional training means just a change of position of the patient. Simple one. So when your patient is changing the position from supine to sideline to sitting, sitting to standing, half kneeling, kneeling, crawling, these all are the transitional training. So as whenever we are going for the any transitional training, our one body part is moving on the another body part. So I think everybody is aware about the body on body reactions, neck on body reactions, which we think that it is only applicable in a CP. It is not like that. In normal human beings, it is also there. So we have to go for the transitional training. The sixth one is the functional use. We have teach them. We have gone for the selective stretching, selective strengthening, balance training, gait balancing, transitional training. But if patient is not using it functionally, then it is a whatever we have done it, it is useless. So if you have teach everything and you are telling a patient, please come up from your chair and come to me. Patient is saying that no, I can't do this, and patient is not doing it functional. Even patient is not taking a one steps forward, try to reach at some places, then it is not possible. So we have to teach the patient how to use whatever they have achieved it in a functional manner. And if all these things will come together in a very nice manner, then we can gain a independence in the patient. So let's move ahead about the comprehensive rehabilitation of GBS. Only two things which is very much important. That is, a plan of care should be customized to the individual patient's disabilities. Means we have to ask that what you are not able to do it. Tell me. So what your patient is saying that not able to do it, it is their restrictions of the abilities. So we have to try to overcome it. And second thing is orthotics may be indicated to compensate some distal weakness. So if it is needed, we can prescribe it. And sorry to say, but some different kind of opinions are there. The orthotic can again lead some muscle weakness. That it is true. But if we are using it for a prolonged durations, and though the patient has the muscle power, and but patient does not have a good control of it, then we can use the orthotic devices. But once the patient is gaining some power, we can discard with it as per the need. And different kind of orthoses are available in the market. So varieties are available. So with a variety, we can go for that things. And that's why I have told you earlier, the rehabilitation is a dynamic process. So we have to continuously changing our atmosphere, continuously changing our thoughts. So, and we can go for the good rehabilitations. So whenever we are going for the rehabilitation, the first things that will stuck to our mind that what patient is feeling. And if I'm not forgetting, when I was a student, whenever we are going for the any kind of physiotherapeutic management, the first aim will come that is gain the confidence of the patient. So how to gain a confidence of the patient? It's not like that we can talk good things with the patient and will gain the confidence of the patient. No, it is not true. We have to feel that what your patient has. So what is patient is feeling, that we have to feel it for the GBS patient. And when we are able to feel that things now, and we will talk with them, at that time we can gain the confidence of the patients, and patient will be an active participant of our plan of care. So when we first meet patient, might be have thoughts like that, will I ever walk again? When I will come back to the normal? Even when it is a time to discharge service, they will ask themselves, will it ever happen again to me? So these all questions are there. That is, which will restrict them, which is not allowing them to be free. And the therapist always be encouraging, hopeful regarding patient's recovery. And one good things which I want to share with all of you, that without making processes about the degree of recovery and time frame, because every patient is unique. I have already explained that some patient is able to work without any support within a 3 months. Some patient might have a residual symptoms are there. If you are going a time frame and you are going the amount of recovery, it is not suitable for the patient. So it can again demotivate them in a future. So don't use that things. So what the patient has, another things, what patient is experiencing, that is a fear and anxiety. What will happen to me now? If it will happen again to me, that then it is because the patient was completely independent in their life, and suddenly one infections, one autoimmune reactions has ruined their life. They are dependent on the others, they are dependent on the caregivers. So they will become some fear and their anxiety. Once they stabilize, the patient is continuously experiencing some anxiety during quiet times alone or during treatment. So therapist has to be active and take their active parts in a plan of care. So they are not become anxious. You are giving less time to them for thinking about their disabilities. The third thing, which is come active, is a pain. Sometimes pain is can be significant in GBS because I have seen that girl what I have explained you at a recurrent of the GBS when she came to our department, and if somebody is going to shifting her na, she is literally screaming, don't touch me, don't touch me, I have so much pain are there. So these all things are there. If such kind of pain is there, and if you will directly touching to the patient, we will assess the patient na, we will not gain the confidence of the patient. So abnormal senses visually occur digitally at a foot and hands, and sometimes it is also in a shoulder as well. So I prefer that always ask a patient for permission before touching them, and think of how their plan of care may be affect their sensory systems. Depressions and guilt is also there. Why it has happened to me? What I have done this? I haven't done this. Why it happened to me? So this is depression and guilt is applicable with, I have found with every neurological disorders. So this understanding is little bit discouraging and leads to apathy and depressions. Our greatest tool is that the active involvement of our patients in a plan of care. That is a treatment for the depression as guilt. I'm not saying that somebody is fully depressive is then you can take the active enrollment. If such kind of thing is there, you can send a patient for the psychological counseling. But if you are finding that the little bit depressions atmospheres are there, you're finding your patient is there, take their active participate. The best way to help your patient is to conquer these challenges and let them to know how they are not alone. Give them a challenges and tell them, yes, I am with you. Just try to do it. You are not alone at these places. We will help you. Wherever you need, we will help you. So it will again motivate the patients and they will come out of these things. Now the main important part, these all things are related with that. If we have an idea about the depressions, fear and anxiety of the patient's pain, okay, then we can gain a confidence of the patients. But for any rehabilitations, evaluation is must. So sometimes the clinical features of GBS and chronic inflammatory, I said you, GBS is an acute inflammatory demyelinating disease, and simultaneously the chronic inflammatory demyelinating diseases are there. These are dramatically similar to each other. So sometimes we might be confused with it. That's why I explained both of things. So physical therapy and occupational therapy is evaluation is imperative to the understanding patient's particular needs. We have to go for our normal assessment. I'm not denying that observation, examinations, palpation is needed, but for this as per the patient's needs, so we can go for the problem solving menu. The evaluation is very somewhat based on the setting of patients which a patient is being seen and as well as the current status of the physiological process. Sometimes we can start a assessment in intensive care units, and then after patient is coming in a subacute, then a rehabilitation part. But sometimes with chronic inflammatory disease patients are there, they might be start with the home base or the outpatient therapy department. So what the first things, that is a patient and caregiver interview. I think I have already explained you. We have to talk with the patient. We can gain the idea about it. What is patient's recreational views? What is the recreational interest? What their goals are there in their life? Okay, what they want to need, and we have to be cautious and be respectful for the patient's emotions. If patient has a too much pain is there, and sometimes as a therapist to motivate the patient not to listen that we are saying that it will be happen. And if such kind of patients are there who are really very emotional, don't use your favorite sentence that is a no gain without pain. It is not like that, because they have a pain. So we have to respect their emotions. And the interview is always also a good time to assess the caregiver and environmental support of that patients at home, as well as what their needs after the discharge. And that's why the interview is important. So sensory assessment, as I told you, we have to ask the patients before placing a finger on them, when they are experiencing a pain, when they are not experiencing a pain. So whenever we are going for any kind of exercises, we have to be careful that their pain is not aggravating it. And if some patient has a too much pain is there, we can use our traditional methods like TENS or IFT for the pain relieving. Skin infections, sometimes that patient is a long bedridden positions, the pressure sores are there. So due to the pressure sores, skin irritations are possibly start. But yeah, if your patient is independent, then don't go for the skin inspections, because itself it is sufficient and cognizant that the patient's skin is all right. Joint range of motions, it is we have to pay particular attention to ankles, knees and hips. We have observed that as the flaccidities are, then if we are going for the early standing for the patient, mainly the GBS patient, so there is a chances of ligamental laxity in them. So later on it will give a patient the pain is there. So we have to pay particular attention to it. If sometimes patient is a wheelchair bound for a long durations, at that time also we have to pay particular attention for the range of motion. So we can get an idea that there is no contractures are there in them. The foot drop and wrist drop is also not uncommon. If joint contraction is suspected, it is again a massive measure to suggest a selective stretching. Then muscle testing manual. Muscle testing, not a movement testing. I have observed that whenever we are going for the MMT, if somebody is asking that, have you assessed a muscle? Yes, I have assessed a muscle. Yes, flexor is a 4, extensor is a 2, abductor is this much, adductor is a this much. But whenever we are talking about the GBS, it's a lower motor neuron lesions. Here the mobility is affected. Mobility is affected means muscle is affected. So if we are assessing the muscles properly, then and then only we can plan a good care for the patients. If you are going for the group of muscles, then I think we will lagging behind at some places. So always go for the muscle testing. And as I think everybody is very well known about it, if power is more than 3 out of 5, we can apply resistance. If less than 3 out of 5, we can go for the gravity eliminated positions, or we can reduce the gravity. And for assessing the grip as well as pinch, we can use a dynamometer as well. Pinch gauge are there, or the functional testings are there. The functional testing. What do you think about functional testing? It is a very much one good things are there, but which will again require a detailed assessment related with one single assessment of functions. This is depending on the bed mobility, transfer, self-care, other functions related to patient's work, in leisure activities, maybe during the initial evaluations. Sometimes if you want to just assess the med mobility, again med mobility, 2-3 things are there. Patient is able to come on a elbow or not. Patient is able to sit by himself or not. If patient is not able to sit by himself, why he is not able to sit? How much support he is needing? He is needing the total support, 100% assistant, 75% assistant, 50% assistant. Depend on that, we can go for techniques. Second thing is mobility. This mobility doesn't mean that the joint mobility. This mobility is the functionally mobile. Is your patient is able to walk or gait, then examine their gait, how they are walking, what is their patterns are there, what the lacking in behind. Because sometimes the single example I will give you. My one patient is there when we have tried to let him to stand, he is not able to stand. As he is going for the standing, and if he has a little bit of support of bed is there, he can able to stand. But whenever he has to take a steps, he is going to take a steps, and there is a buckling of knee, and he is going to fall. When we have assessed a patient carefully, we have found that okay, knee muscles has some power, but soleus is not working at all. So whenever he has to change a line of gravity, whenever we are going for the walk, the line of gravity is changing from posterior to anterior. As the line of gravity is shifting from ankle from posterior to anterior, there is a the tibia is going for the anterior translation, and there is a buckling of knee. So what we have done? We have done nothing. We have just given them AFO. The tibia is stabilized, and once the tibia is stabilized, patient is walking very nicely. So this kind of minor changes can help a patient a lot. But yes, if perfect assessment is needed, good evaluation is needed. If your patient is on a wheelchair bound, then assess in a wheelchair. The observations may be performed, what they are able to do, what they are not able to do, and we have to assure at every time when you are assessing the patient, don't overexhaust the patient. Sometimes as a therapist, we want that patient has come to us today, we will examine everything today, but it will over-exhausting the patient. And this is also sometimes a lacking atmosphere for us. We have experienced very nicely because we are already our rehabilitation is in a rural-based rehabilitation. So sometimes patient is coming from the 700 kilometers, 800 kilometers, 900 kilometers away from us. They will come to us when we are asking them, take your limb up, they will take their limb up. And whenever we are applying it, we find that their strength is not there. But after 1 or 2 days, they have take a proper rest, and immediately we will observe that they are quite fine. They are doing it very nicely. So it is not like that we have done something, but already the patient was exhausted from the traveling. So same thing, it can be happened with us when we are assessing a patient. The patient is totally exhausted. We are not getting a clear-cut pictures. So that's why if patient is over-exhausted, we have to postpone our assessment. So other assessment is also very much important. The respiratory assessment, because I have already told that the respiratory functions are also affected if in GBS. Deep vein thrombosis are also there because the muscles are not working. Patient is immobile in the bed. So deep vein thrombosis are there. We can assess the calf pains, okay, swelling, edema. Sometimes the autonomic dysfunction is also affected. It might be related with the positions, or it might be related with some autonomic interference. But a simple one common thing is that is the orthostatic hypotension. As patient is from a prolonged bedridden position, if they are coming in a standing position, they have a postural hypotension. So this is also common. The one thing which is very, very, very important with the GBS, that is the endurance. We have to check their endurance, and as per their endurance, we have to plan our treatment. Patients should not be tested to exhaustion, since recovery from the fatigue can take some time and will delay the rehabilitation process. process. If patient is exhausted, our rehabilitation process get prolonged. That's why in between rest is needed, and we have to plan our treatment as per the endurance of the patients. Now let's move ahead for the treatment. So treatment, I have already told that our two goals are there. That is one, to help the patients to achieve a optimal muscle use at a tolerable pain level as the nerve supply returns. And with that, we can achieve a normal functions, normal functional trainings, and independency of the patients. With that, if it is needed, we can go for the supportive equipments as well as other functional adaptations to help the patients with residual impairment to resume in activity. Sometimes it is not like that. That's why I have mentioned earlier. Don't overestimate. Sometimes you know that your patient is totally recovered, almost 80%, 90% recoveries are there. But you know that you are going for since last 3 months, you are working on their hand, you are working on their foot, but still the dorsiflexion is not there. Patient is able to use the fingers, but patient's fingers are in this way. So their intrinsic muscles are not there. So you can't wait for that thing. Let the effort nakar means claw hand is there. They are not able to hold anything. But with the simple adaptive devices, if you give them a lumbrical grips, with their thumb, they can hold at least something. If they are able to hold something, they can do their functions. If at that time we are saying the patient, no, no, wait, it will come, wait, it will come, wait, it will come. So ultimately, the patient will not able to do their activity by himself, and it will limit their activity. Ultimately, it will lead to dependency, and ultimately, it will make a patient handicapped. So this is our responsibility. That wherever the supportive equipment or adaptation is needed, we have to give to the patient. I have already mentioned that every person with GBS will responsive to pharmaceuticals as well as the other medical treatments as well as the therapeutic way. It's not like what might be possibilities are there. Me, if somebody is telling me, sir, you have to walk for a 30 kilometers, I might be able to walk for a 30 kilometers. But somebody will tell me you have to run for 300 meters. I might be not able to do this. But when another guy is there, somebody will tell him you have to run for a 300 meters, they will run very quickly. But if somebody will ask him you have to walk for a 30 kilometers, they are not able to do it. So even two persons are there, no normal persons are not same. So how we can predict that every GBS patient is same? So every GBS patient will respond to exercises, our therapeutic approaches differently. So many times we are using that sentences and we are strictly telling the patients, don't compare your improvement, don't compare your exercises with the another patients, because every patient and every even therapists are unique. So consequently, it is essential for us to keep in mind that the body is only will do that what is capable physically of doing, regardless of expecting of the patients and the therapy staff. I'm not saying that only the patient's expectations are high. Sometimes when therapist expectations are also high. Array, this therapist has done a good job. Now I have to also do these things. So it is not good thing, because ultimately the body will respond as per the capacity of the patient itself is there. So it is not like that it will work as per our expectations. And always use a safety first approach. Whenever we are working with a GBS patient, the safety is very much important. Here, I already told you, the patient has a flaccid paralysis. If we are going for the patient is going for the one position for a longer duration, if extra pressures are there might be a chances are the patient will lose the balance. Lose the balance ultimately has a history of fractures. I have a 2-3 examples are there with us also there. We have already had one a good example I can share with you. My one patient is there. We had tell him they have to wear a AFO and he has to walk. He's walking very nicely. He's totally independent in his life. Okay, he's driving a motorbike. He's able to do his all vocational training. But at home, he has realized that the one another patient we have it and she is walking without AFO. So he thinks that I also want to walk with her without AFO. He has started it. He has the leg is stuck with the floor, and he has met with an fracture of first metatarsus. So these possibilities are there. That's why safety first. And that's why at that time patient is saying that, no sir, you have said me it is the right thing. But always we have to explain the patients why we are telling in that. So that's why the comparisons, the expectations is not allowed, and safety first. It should be there. So what we can do in an acute stage, I think everybody is aware about that. In acute stage, whenever we are going for any intensive care unit, passive movement, we have to maintain a airway clearance. Patients' positions are there to change the positions every 2 hours. We have to support the weak muscle. Here it is very much important things. Sometimes if shoulder muscles are not working now, then and patient is allowed to sit now, there is a chances of shoulder subluxations. And if shoulder subluxations are there, we are finding very much difficulty to gain a good functional control of the upper extremity. So whenever we are finding in an acute stage, some weak upper extremity are there, we have to give them an armrest, we have to give them a proper wheelchair tray, we have to give them a pillows, and we have to prevent the stretching of muscles and joint structures. And that's why I told you selective stretching. Don't stretch every muscle or don't strengthen every muscle. Because sometimes I have heard the physiotherapy means stretch the tight muscle, strengthen the weak muscle, but it is not applicable everywhere. The first things which I want to say, that is educate. And these educations, it's not related with the patient, it is related with the therapist. Therapist has to educate themselves for patients' home life, how they are working at home, their work demands, which kind of work is needed from their body, their recreational interest and support system in order to customize the patient's plan of care. When we are going for the any planning, we have to educate ourselves with patient's need at home, at work atmosphere, as patient's recreation means patient's hobbies, what he likes, what he do not like, and support system, that is the environment. If somebody is ready to support them or not. This will include not only the personal support, it is also include the environmental support in the form of modifications, the infrastructures, barrier-free infrastructure is needed. So all these things will be there. Third things I want to say, that second thing, that is we have to anticipate. With our assessment, with our experience, I think everybody can anticipate little bit about it. I need this kind of assisted device in future or not. There might be chances that in future this patient might develop a tightness in these muscles. If tightness will develop, then it can hinder in my progress. It can come in the way of rehabilitation. So such kind of anticipation is needed. This anticipation means anticipations about the assisted devices or the adaptive equipment, which can be useful for the patient in future life. But whenever he or she has to use in future life, but we do not have given them a training, whenever that means moment will come now, they will become anxious. What I have to do? They are not able to understand that how I have to do this thing, how to perform that things. So at that time, our anticipations prior to it happen, it will help us. And that's why in postural control, one good thing is the anticipatory postural control. We are sometimes training our patient for these things. So this thing is also important over here. So, and use gentle passive range of motions to reduce the risk of contractures and DVT. We can introduce breathing and coughing. And one third things, that is a communicate. We have to communicate clearly with the patient. If you are showing one exercises, now tell them why you are going for these exercises, how it will help you in the future, how you will progress it in the future. Because simple thing is, if you have gone for the 5 repetitions today, you can tell that your patient that, okay, you have done these 5 repetitions, we want to increase up to the 25 repetitions. Until we are not increased up to the 25 repetitions, we are not able to walk. So we can motivate the patient, and as well as we can also explain them what is our future goal for the patient, what is our estimations are there with the patient. So clear communications is very much important with the patients. That is the before as well as the during our physical interventions. And second is the recovery. Whenever the phase come of recovery, we can expand activities gradually as per the patient's muscle power. If it has reached up to the less than 3, we can go for gravity eliminated, the reduced gain gravity. If grade 3, we can go for the resistance training, manual resistance are there. We can increase the repetitions. As I already mentioned that, here GBS, we want to work for the endurance training rather than on a power training. So first of all, if patient is able to do the 10 repetitions, first try to increase the repetitions. So if patient is able to do for 5 counts, go for a 10. If patient is able to do for 10, go for a 50. So slowly increase the repetitions, and then after, if patient is able to do it, then we can increase the resistance. And for that, we can also use a proprioceptive neuromuscular facilitations, because it is again in this technique, the functional use are there, the functional movements are there. We have to teach the patient the energy conservation, how they can save their energy. because some exercises are there which will need a high amount of energy. These patients initially they will walk with a walker, so already their fatigue level is high, their muscle weakness is there, and they have to lift a walker. They have to take it forward. So if we are walking with our legs is only moving, the other body is stabilizing. But here, their hands are also working, upper extremity is also working. Their weight have to bear a weight. They have to transfer a weight on the hands. So it will increase their energy expenditure. So we have to teach them energy conservations by pacing or by breaking the task into the steps. The fourth thing that is that we have to train the caregivers in proper body biomechanics, because sometimes we have seen that the patient will become all that, the caretaker will come again to us and say, sir, I have too much back pain is there, I have to taking care of this patient. So we have to teach them a proper biomechanics for the transfer and positioning of the patients. Here I have put two photographs. One is of the wedge and second is of the stool. Wedge, because whenever we want that the patient will come from supine lying to sitting. If we will assume that the supine lying is a 180-degree position, and if you want to come in a sitting position, it is a 90-degree position. Means your abdominal muscle has to travel from 180 to 90 degree. So ultimately, and even this way also the holding is very much important. If we will look at if we will divide in a part now with a fractions of second, our part is moving from here to here. Then they are holding, muscles are holding there. Then again one booster will come, it will come over here. Again some booster will come and they will align the position. But yes, it's like a movie. We all are aware about that the movie is nothing but it is a collection of photos which is passing very fast, okay, in front of our eyes. Same thing is happening with our normal and smooth movements. They are also one kind of photos. They are a part. But as it is happening very quick now, we are looking it as a one complete movement. But ideally, it is breakdown in a part. So once we will train the patients for let them to come from the 80 to 90. Once patient is master with it, then 70 to 80, then 60 to 90. Slowly, 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 slowly. At last, if patient is gaining some strength, then we can put patient in from the zero level. Or again, if patient is coming from a 70 to 80, in 70 to 90, we will first tell the patient to go for the third degree, then fourth degree, then fifth degree. One patient is able to complete it with the fifth degree, then we can decrease the level. Slow progression is very much important. Same thing is related with the stool. If you will see that the different height of stools are there. This every stool is increasing by the 3 inches. 18, 21, 24, 27, 30 inches. So 30 inches means almost 2.5. So whenever you will see that now, once patient is when you learning to sit to stand, directly they can't stand up themselves from the 90 degree to 0 degree of positions. So it is a reverse to lying. So slowly they will gain it. So here we will tell them you have to control your body and try to release your body just about a 2.5 inches length, 2.5 feet length. Once patient is master with it, then we can tell them to decrease the height. So slowly by decreasing the height, we can gain a good confidence as well as the good recovery in the patient. So as I mentioned that once sufficient active movement has returned, the therapy session will begin to focus on patient's ability to perform daily activities. Wherever is possible, I think that we have to work in a real world because we want to work on a patient endurance. We want to work on energy conservation. So if we are telling the patient go for 25 repetitions, hip flexion, extension, abduction, adduction, knee flexion, extension, we know that if one joint is there were 6 movements. If you are going for the all body movements of 25, then patient's all energy has been wasted in that. So whenever we want to work them actual in environment, they are not able to do this. And one good example I have put it is it doesn't mean that we are not going for that things. Initially we are teaching the patients, but later on as patient has a active movement is written sufficiently, then and then only we are putting patient in a real world. So you are just putting a one cones at one places to another, pegs to one places to another. It doesn't mean that you are able to eat your food because the different thing is needed. If you are able to extend your knee for 25 times, you are able to extend it hip 25 times. It doesn't mean that you are able to stand by yourself. So ultimately, patient has to work in a real world. So whenever we are going for any activities, we have to tell the patients that and let them to practice in a real world. What your balance training is there, stretching is there. So all these things be there. What I want to say, we have to customize the exercises. The customization means we have to strengthen the weak muscles and watch for the muscle substitution. Whenever we are going for the any activity, I given you one example. That patient is in a high sitting position, he is trying to touch the floor. So here patient is, he has to use a back extension. But as a substitution, he has a good latissimus dorsi, so he is using a latissimus dorsi. Same thing is a gait. If patient does not have a good hip flexors, they will go for the circumduction gait with a hip hiking. So we have to customize our program in that way, the whichever, and we have to look for the substitutions. If patient is using some substitutions, then we have to overcome that. Okay, and we have to again strengthen the patient so that they will go for a normal movements. We have to plan multiple rest breaks during therapy if fatigue occurs. It's not like if patient has gone for the 5 repetitions, we know that patient is exhausted, let them to rest in between. It sometimes it looks different. Sometimes we are practicing in that way. It's look little bit means awkward for the patient. If you are telling them now, you need a rest, you will go for a rest. So sometimes young guys will come there and say, I am a young one, I don't need a rest. Some patient will explain that. So what we are doing sometimes, please be for 5 minutes. I will come by drinking a water. So in same way, you have to take means you do not take patient directly. You can take a rest. You can change in another way. You can take a rest as well. So these things are very much important because so many persons are that they are enthusiastic, and this enthusiasm sometimes will means restrict our rehabilitation process. So these are some examples are there. The different exercises are there. So patient can go for the balance means breathing. Simple breathing is there. Once patient is able to do breathing on a leveling, we can give them a balance board so they can do it. Once they are able to do it, we can teach them. They can move their legs up and down. So this is it's not a real word, but we can explain it. Whenever you are going for the walking, you have to maintain your trunk, and by maintaining your trunk, you have to lift your one leg up and one leg down. And whenever you are lifting one leg up, your another leg is going down. So patient is getting a proprioception as well as the sensory feedback as well. Same way, if patient strength is not enough, so you can see that the one way as a quadricep has a good power, we are going for the against gravity with resistance. But if it is little bit less power is there and we want to work in a full range of motions, we are going for the sideline here. So these all things are here. The means hamstring has a good power, but it can't work with a resistance. So without weight, patient is doing these things. If we want to go for a external internal rotations against gravity, the patient can go in a sideline. So positions change of the patients, and as per the patient means strength, we can change continuously the things. Same way, the transitional training. This is one of the example for the transitional training. How the patient can go from the crawl to the means kneeling position. First of all, patient will start a crawl. They will maintain their balance. Once they are able to maintain it, they can go for the leg lifting. Once they are able to do it, they can go for the hand lifting. Once they are able to do it, they can slowly try to come up. Once they are able to come up over this way, they can put their hands. If they are going to fall, they will be ready to put it by down. Again, they will come up to the 90-degree. Once they will come in that way, we can hold them, tell them, you can hold the position and you can go for the upper extremity strengthening exercises. So simultaneously, we can work on a 2 directions. So this is the example of transitional training. Same way for the pegboard exercises, it's not like that we have to work only a 1 or 2 muscles. We have to work in a multiple ways. You can see that here what patient is doing, he is just going for the extension and flexions. Here patient is trying to use his wrist extension and that. If you will observe that here, what he is doing that he is trying to use a tenodesis grasp over here. When he has to release it, he is going for the, you can observe that there is a means wrist flexion is there whenever he wants to leave it. Here again for releasing he is doing that things. So this patient is able to do his activities but with a tenodesis grasp. So but he is able to function it. So we have allowed it for some time and simultaneously we are strengthening the which your weak parts are there. Same way I have told you how to work in a means part wise. Here I want him to stand. So what I have told him, just first try to lift your body from the weight, from the plate. Once he has tried to lift it up, I told him you can hold it for some time. If you are able to comfortable it, you are fine with it, there is a no fumble is there, then slowly I have told him you can lift your one hand up. Alternately, he has started to lift his one hand up, one hand down. As he has mastered with it, I told him you can lift your both hands up. Once he has hold it, I told him you can hold it for some times. Then I told him you can now take your both hands up and try to hold it. Then slowly, I told him, if you need a support, take a support from the back and try to get it by yourself. So slowly, he can come in this. So these how to break apart. If you will tell this patient directly, put your hands on the planes and get up. So he is not understanding that how I have to do it. So we have to teach them in a component wise. First of all, you have to lift your body up. Then you have to maintain your balance. Once you are able to balance it, you can slowly leave your hands. Sometimes what's happened whenever we will ask the patient to leave the hand, they will use a third low. Then they will completely just press it very hard now. Then the action reactions, they will press it very hard and ultimately it will throw their body away from the line of gravity and from the base of support. So that's why we have to train them slowly you can release your body. So this way we can train that way. Same way, this is another example. So again, C is also going in that way, where one C is able to do it very nicely. So C is doing all activities against gravity. And same way as a functional training is needed. What we have done that C needs a upper extremity strengthening as well as C need a standing. So C is standing in a standing frame, and with a standing frame, C is going for the upper extremity exercises. Once she has mastered with it, initially when she had started a stair climbing, she is climbing a stairs with a AFO. But as the strength has came, okay, she has gained some strength in a soleus as well. And there is a less chances of knee buckling are there, less chances of tibial translations are there. So we have allowed her to walk without AFO. And she is also performing very nicely with it. So what we can do, once we have achieved all these things, now the second phase will come. And that is we have to establish a home program. So we are going for that exercise, but what about the home? So we have to establish a home program that fits the patient's current activity, and as soon as the caregiver can be demonstrated through the understanding of the exercises. Second, we have to provide a variety of additional activities that promote the gross and fine motor skills and sensory stimulations for the patient. Third one, we have to provide a patient with an adaptive and compensatory rehabilitations. Means whatever is needed, we can tell them. And again, continue follow-up of the assessment until the patient is not fully independent in his life, physical, psychosocial, as well as the social. So these are some examples. He has already learned all the movements. Okay, so what we have told him, he wants to, what I can do, you can do one thing. You can just wash your face by yourself. That is enough for your exercises. Okay, you can drink water by yourself. You have to drink by yourself. Okay, if you are not able to break a chapati, initially you can go for the turning of papers. So which slowly they will learn it. Then dressings will come. Sometimes if they are not able to walk very nicely, they are not able to transfer themselves, then they can use the adaptive devices for the urinations as well. And we have to, that's why I told you now, that new skills. You will teach them a new skills, but what are the strategies? Without strategies, they can't work in a good way. Same way, I think I have already told you how the adaptations, once you have done very nicely, but what if it is not able to do it? So he does not have the grip at that time, but he wants to mobile himself. So what we have to do, we have put the knobs over here. So if knobs are there, with that knobs, he can just put his hands and he can be a mobilizer. Those single change, single modifications can make him independent and mobile by himself. With him, his mother and fathers are there. They both are the senior citizens. So for them also to drag him, and he also more than 100 kg. So to drag him from here and there, it is difficult for them things. But if he is able to do it, it is good for them as well. Or sometimes if it is needed, this is an external appliances. Sometimes it needs some modifications, so we can put a orthosis. Here patient has a claw hand. So we have just given them this kind of space so that their limbs, their MCP joint will remain in a little bit of flexion. If it is in flexion, their fingers are already moving because long flexors are quite fine. The lumbrical is not working, but long flexors are quite fine. So she can do her activities. So this kind of changes we can make in a patient. As I told you, when we are putting a patient through the normal real world, we have to sensitize them. This is a patient where we have sensitized them how you can sit on a bike if you want to sit behind a bike, how you can get into the car, come out of the car, how you can use a buses, how you can use the train, train as well. In our department, we have a set up a public utility service area training center where we are sensitizes all these patients over here as well as the senior citizens who are little bit anxious about to go outside because they do not have a confidence that I am able to use it or not, and that will make them anxious, depressive, and if they are able to do it, they have practiced it very nicely, and then we are putting them in a real world, it will be good for them and they will practice it very nicely. I can tell you this guy is coming for the exercises by driving the bike by himself about a 70 kilometers, coming for the exercise and going back by himself. So you can see that how the confidence will increases. So again, then after the vocational training is also important. Vocational training doesn't mean that we have to just change their occupation, but sometimes we have to think that what the patient is doing there. This is a guy, so he is a wholesale dealer. So he is just applying a dry fruit from one shop to the another shop. So and he is in a Bombay. So we know that in Bombay, if two wheelers are there, you can travel here and there easily. But with a four wheeler, you will be stuck in a traffic. So he's not able to do this. So initially we have trained him. You can just sit on a Activa. You can just put your one leg up and down. Then you can just shift weight on that. Initially, he noted how to drive it, but for his confidence, we have sit behind him for some time. Then he has mastered with it, and ultimately, as he has done very nicely, he is doing it independently. And once he has gone from our rehabilitation center, he is doing his job by himself without taking help from the others. Same way we are also training patients in our modified kitchen. So if girls are there, housewives are there, if they have to work at home, it's a dummy kitchens are there. Here also we are taking safety measures that patient will not getting stuck to at any places, patient is not getting injured. So we can teach them a safety measures, and once they are going back to their home, they can do it very nicely. And I have explained you, we have to give them some recreational activities and means different kind of exercise where patient is interested. She needs because her hands is not quite fine till date. She needs some exercises for that. So what we have done that she has to hold a medicon and she can make a designing. So it needs a precision. It needs a fine motor work. So she can do that thing. She can again go for polishing her nail as well with nail polish, because if it is going from here and there, then she will don't like it. Here we are not a judge. Sometimes we are all the time shouting on the patient. You have done in a good way. You haven't done in a good way. So sometimes patient is not even we don't like it yet. So if we have to judge ourselves now, then it is easy and we are more motivated by ourselves. And once if it is patient is able to do it very nicely, then they can go back to their life and they can do it very fast and in a normal way. If you will observe that now, what she is doing that still her intrinsics are not working. You can see her hand. How she is putting it in this way. She has been given a splints, but she is not fine with it. Okay, that's why she is doing without splint. But yes, already all strategies, all new skills has been trained to her. See how she is doing that. She is flexing it and then she is drawing that. So what is our aim? Our aim is nothing, but as patient is an intensive care unit, he is a very intubated with this and that. Then he is coming out of it in a subacute phases. As he is coming out from the subacute phases, teach him some mobility training, make him able to stand, make him walk for some times, let him to spend some time with the family. As he give us some time to the family, let him try to work. Initially, if supportive devices are needed, give them a supportive devices. With supportive devices, let them to work independently, because it will gain a confidence. And as they will gain a confidence, slowly teach them everything. Go for a vocational training for the patients. Let them to work by themselves. He is a clerk in a government offices. So after these things, he has applied for many examinations. He has covered with it. And when he was here, at that time also he has appeared for the CCC exams. So these all simple thing is that, but with our good rehabilitation, we can give them a good feedback. So as with our adaptive devices, he make a independent. So you can see that initially how he is using a chair. Once he is using a chair, he's become independent. All these things, he's writing by himself in a standing. Whatever normal writings are there, and normal walking has came. and ultimately he has received some prestiges from the societies as well. So our main goal to put the patient from the ICU, from the intensive care unit, we have to put them in a intensive community unit. So from ICU to ICU, because there they need a typical care, and in a community they can take care of others. So once the patient is able to take care of others, our role is finished. So thank you all for patience listening. Thank you so much.
Thank you, sir. It was a wonderful explanation of GBS rehabilitation. Exactly, we can say the ICU to the intensive community rehabilitation. Yes, and I would like to heartily thank Dr. Ashok Trivedi on behalf of therapy for sharing your experience with the patient and enlightening us with that knowledge. Thank you so much, sir.
Thank you.